So this section will be going over a couple of different neuro disorders. Now, quite a few of them, there's nothing really EMS you can do with it. It's treating and managing any potential life threats that may arise from them. So the first one I'm going to talk about is vertigo. Vertigo is just a subjective sensation. That's important because we can't see if they're dizzy. Okay, we can't tell, so we're going to have to rely on them to tell us this. They may, some people do confuse dizziness and lightheadedness, so it's important to find out, when they seem like they're spinning or whether the movement of the environment itself is moving or if they feel a faint. And some people will get these confused, so it's important to ask them to describe the sensation that they are experiencing. Now, vertigo can be accompanied by some nausea, vomiting, nystagmus, abnormal eye movements there, and may be precipitated by sudden movements of the head or certain positional changes. This vertigo can be caused sometimes with the structures of the inner ear, the 8th cranial nerve, or even a problem in the brain stem, or insufficient blood supply or stroke. So a lot of different things here. Now, some people do have a history of vertigo, which they might be a benign paroxysmal positional vertigo, just depending on what position they are in, or shifting positions rapidly, or they may have a history of Meniere's disease. So as far as how this affects us, in and of itself, not usually going to be an immediate life threat, but our biggest thing here is that movement's going to make it worse for the patient, and this patient's more prone to falling and being injured. So we want to be very careful if we are moving them or asking them to move or anything like that. Now, non-traumatic back pain. Usually this one is going to be from some kind of impingement on your spinal nerves, maybe a herniation or rupture of an intravertebral disc or something like that. So they may have pain, they may have weakness, numbness, tingling, or pain along wherever that nerve goes. So, with this pain, it may be severe enough to warrant giving analgesia before moving that patient. If moving the patient is going to significantly increase the pain, maybe consider checking with medical direction about analgesia there. A big key responsibility here when assessing a patient with this is to consider any serious medical conditions and life-threatening causes of back pain. Think like abdominal aortic aneurysm, pyelonephritis, peptic ulcers, pancreatitis, diverticulitis, PID, some other things that could potentially cause a life threat. And another thing, especially in your older and immunosuppressed patients, is the herpes zoster virus, or we know as shingles. And so with this, that will cause pain on one side. It'll be unilateral. And they may have that pain for several days before the rash actually, or the blisters start to form. So keep that in mind as well. Shingles is contagious, so just be aware. Now, with your central nervous system infections, there's a lot of them. So this is just kind of an all-in-one. But encephalitis, meningitis, brain abscesses, all of these can produce neurological signs and symptoms. Now, of course, your encephalitis is just inflammation of the brain by a viral infection. This could be herpes, could be the West Nile virus, things like that. Most common signs and symptoms are going to be new onset of psychiatric symptoms, cognitive deficits, confusion, headache, movement disorders, photophobia, and fever. Now, your meningitis may be viral or bacterial. Bacterial usually presents with a gradual onset or a very sudden, severe, and aggressive presentation. Now, we know that there are concerns sometimes about outbreaks of bacterial meningitis among school-age and college-age populations and elderly populations like in nursing homes. Our signs and symptoms are going to be photophobia, stiff neck, headache, fever, altered mental status, and occasionally some seizures. And they may also have a hemorrhagic skin rash, purpura. And they may present in shock. Right? One of the classic signs of meningitis is the Brzezinski sign, and that's where the patient's neck is flexed, so the chin is moved towards the chest and the knees flex in response. So you move the chin down, the knees should flex in response to that. Okay, remember that meningitis, bacterial meningitis, can be spread through droplet spray, so you need to wear a face mask as well as any other N95 or other indicated standard precautions. Now, a brain abscess is going to be focal or localized. It could be bacterial or fungal in nature. And this abscess can occur from an extension of an ear, sinus, or tooth infection. So they can actually travel into, from somewhere around the brain into the brain itself. Or it can be from pathogens from the blood, IV drug abuse, or infections somewhere else in the body. Your patients who are immunocompromised are going to be at your greater risk here. Most common signs and symptoms are headache, seizure, and fever. Now, one thing to note with all three of these, they all present very, somewhat similarly: fever, headache, seizures, altered mental status, that kind of stuff. We don't have a way in the field of differentiating the infectious from the non-infectious. So assume for your safety that it's infectious if they're showing these signs of symptoms. Now, a couple other assorted neurological disorders. Bell's palsy. It's a temporary weakness or paralysis of the facial nerve, cranial nerve 7. Okay, these may, and some people are more prone to this. They think that the herpes simplex virus may play a role, but they're not sure. Pregnancy, diabetes, exposure of the face to really cold air can increase the risk of Bell's palsy. The signs and symptoms often have onset during the night, and they wake up with them. In addition to your weakness of the facial muscles, they may drool, lose sense of taste, numbness, have excessive dry eye or excessive tearing. A big differentiation between a stroke and the facial nerve in Bell's palsy is that the forehead generally is only in Bell's palsy, leaving the patient unable to raise an eyebrow. The Bell's palsy can look like a stroke, but it's not. All right. Be very careful until the diagnosis can be made with certainty, but the majority of your Bell's palsy cases resolve completely within several weeks, but some may have a few ongoing effects. Normal pressure hydrocephalus. So, with this, it's not really normal pressure because the intracranial pressure can actually increase in these patients, but unlike patients with congenital causes of hydrocephalus, the collection of CSF that causes increased pressure here is more gradual, so the pressure's not as high. So what happens here is the CSF produced in the ventricles of the brain can't be properly reabsorbed or drained, so it collects in abnormal amounts. This is more common in your older populations, greater than 55, and there's often a history of some kind of subarachnoid hemorrhage, traumatic brain injury, or something like that. Now, some of the earlier symptoms can actually overlap with some of the cognitive impairment of like Alzheimer's disease or motor impairment of Parkinson's disease, so this diagnosis can be a little bit delayed. It's characterized by a kind of triad of ataxia, which is loss of coordination, dementia, and urinary incontinence. Once this problem is diagnosed, they may place a shunt to drain that excess fluid. So for us, EMS, there's nothing we can do but just recognize signs and symptoms and transport to appropriate facility, manage any life threats, ABCs, as they occur. Now, your Parkinson's disease, right, typically occurs in patients over the age of 50 but can occur earlier. And what's happening is that we've lost dopamine-producing cells of the brain, resulting in a movement disorder. Early signs and symptoms are very subtle and have a gradual onset. They can include tremors, muscle rigidity, slowed movements, problems with your balance and coordination. Now, with this, it's progressive. Medications can help, but, once again, like most of these, very rarely are you going to get called out to somebody's residence and they're going to be like, oh, hey, and you're going to be like, oh, you know what? I think you have Parkinson's disease. Usually they're going to have a diagnosis, and we're just going to be treating any problems that may come along with it, like falling, injuries, things of that nature. Now, with multiple sclerosis, it is an autoimmune disease, and there's the myelin sheath of the nerves is destroyed, so it results in problems with nerve conduction. Usual onset is between ages of 20 and 40, and can include difficulty with vision, muscle weakness that can actually lead to paralysis, abnormal sensations, and occasionally cognitive symptoms as well, like depression, poor memory, etc. Pre-hospital, there's nothing, we can't fix this. Once again, they're probably going to present with a history of it, and we're going to be treating any ABC issues or any immediate life threats. Now, myasthenia gravis. This is an autoimmune disorder with the acetylcholine receptors in the skeletal system are destroyed. And so, with this, we're going to have some muscle weakness. Okay, the facial muscles may be affected. Respiratory muscles can also be affected, so they may require some assisted ventilations. Your medications can decrease the severity of some signs and symptoms, but be prepared to support your ABCs as needed. Your two emergencies associated with it are going to be a myasthenic crisis and a cholinergic crisis. So the myasthenic crisis is going to be when they don't receive an adequate amount of medication, and so they'll have muscle weakness, paralysis, wheezing, increased bronchial secretions, respiratory failure, and diaphoresis. The cholinergic crisis, when they're over-medicated. So they're going to be very similar to the presentation of your organophosphate poisoning, interestingly enough. Okay? Manage your ABCs. Treat any immediate life threats. Transport to appropriate facility with a good history. Right, peripheral neuropathy is where the nerves, the peripheral nervous system, are destroyed. Your patients with your diabetics are especially prone to this and may have decreased sensation in the lower extremities. And with this, between that and the poor healing and common infections, that's why you see a lot of your patients who have diabetes. You go, but if you see them repeatedly over time, like they seem to get smaller because they shut off chunks of them as they go. They take a toe, then they take some more toes, then they take the foot, then they take the lower leg, then they take the upper leg, and so it just kind of progresses along. But peripheral neuropathy is really bad long term for these patients. And your signs and symptoms: pain, burning sensation, numbness, tingling, weakness. All in these affected muscle groups. So for us, what do? Manage life threats, transport appropriately. Now, your tardive dyskinesia is a permanent side effect of taking some kinds of medications, specifically some antipsychotics and antiemetics. Right? With the tardive dyskinesia, they often suffer from repetitive involuntary movements. It could be grimacing, blinking, smacking, puckering of the lips, things like that. Right? Now, compared to that, an acute dystonic reaction is a temporary side effect to taking those same types of medications. And also can be found in patients who have purchased illegal drugs, who don't know, what all is in the illegal drug. Now, the life threat here may be if they have a spasm of, say, the pharyngeal or laryngeal muscles or something like that, then that could compromise the airway. Usually, though, that's not common, so it's not going to be any significant immediate life threats. The treatment for your dystonic reaction: Benadryl, diphenhydramine, right? Wernicke-Korsakoff syndrome. So this is kind of a spectrum of disorders, and it includes Wernicke's encephalopathy and Korsakoff's amnesic syndrome, and both are caused by a thiamine deficiency, and is more common in alcoholics and patients with severe eating disorders. They will both present with, vision impairment, confusion, decreased level of responsiveness, potentially for hypotension and hypothermia, ataxia. Most pre-hospital protocols are going to include the administration of thiamine along with D50 and fluids as indicated, but check your local protocols just to make sure.